Hi everyone. I decided to take a little break in between recording the last PowerPoint and recording this PowerPoint because I realized I sounded disgusting. So hopefully I'm not going to be coughing or sneezing throughout this lecture. So hopefully it's a little bit smoother and more tolerable for you guys. So we've kind of talked about arteries on a broad sense. The main purpose of them, as we know, is to get oxygen-rich blood from the heart to the distal tissues in our fingers and our toes, etc. We're going to talk a little bit more in depth about how that relationship happens and kind of the physical concepts, meaning like physics concepts, behind how fluid behaves in the arterial system. It's a little bit more relaxed in the venous system, as we know, but in the arterial system, it has to be a little bit more precise, and it's a little bit more important, I guess we can say, than the way that fluid behaves in the venous system. So we're going to kind of get right into it. Just a brief little recap here. On a broad sense, the arterial system, like we said, is responsible for carrying blood from the heart to those distal tissues through smaller and smaller arteries. It is a multi-branch elastic conduit. Conduit is just a fancy word for pathway for blood transportation. And every single heartbeat that is going to come from a cardiac contraction is going to be approximately 70 milliliters of blood that's entering the aorta with every single heartbeat. So that right there, that process is going to cause our blood pressure pulse. Our blood pressure pulse is what we're looking for when we're evaluating the arterial system, especially our jobs where we're looking at those more distal arteries, the arteries in the legs, the arms, the fingers, toes, etc. We're looking to see how that blood pressure pulse is behaving in specific locations. So we're going to come back to that kind of 70 milliliters per cardiac contraction. So the cardiac contraction itself, we're going to be originating with venous blood in the IVC or SVC coming into the right atrium. At this point, all of this blood has drained the distal tissues. So it's kind of not really, there's nothing really important to this blood. Now it needs to be refiltered through the heart and through the lungs. So we're getting this oxygen poor venous blood that came from everywhere else in the body. If it came from the lower half of the body, it's coming into that right atrium through the IVC. If it came from the upper half of the body, it's still coming into that right atrium, but it's coming in now through the SVC. So IVC, inferior vena cava, for the lower half of the body, SVC, superior vena cava, for the superior half of the body. Now, once you have that venous blood in the right atrium, it's going to go into the right ventricle, and it goes through that ventricle by a tricuspid valve. So tricuspid, bicuspid, it's just talking about the flaps that make up that valve. So the right atrium into the right ventricle is going to be through a tricuspid valve, 3 little flaps of tissue. From there, in the right ventricle, we need to send that blood to the lungs to become oxygenated. That's how that blood is now going to receive more nutrients, and it's going to be one step closer to being ready to be sent out to those distal tissues through the arterial system. So we need to get it from the right ventricle into the lungs. We send that into the pulmonary artery through the pulmonary valve. So the right ventricle is going to have a little valve that leads into the pulmonary artery, and the pulmonary artery is going to take that blood, it's still deoxygenated, and it's going to dump it into the lungs. So it's going to split. One's going to go to the left lung, one's going to go to the right lung. Okay, so pulmonary artery to both respective lungs. Once it's in the lungs, it's collecting all of that oxygen, it's removing all of that carbon dioxide, that CO2, and now it's becoming this clean, oxygen-rich blood. So now we're ready to send it back to the heart, right? Because the lungs did their job, oxygen-rich blood. Now we have to send it back to the heart so that the heart can send it all the way out to those distal arteries and sites. So it's going to go back to the heart, back into the left atrium by the pulmonary veins. So the pulmonary veins are going to dump into the left atrium. The left atrium is going to enter into the left ventricle by the mitral valve. And then the left ventricle, that's the last stop of this oxygen-rich blood, is then going to be shot out into the aorta through the aortic valve. So kind of piecing that all together, just a broad sense of what that pathway looks like. And a pretty straightforward diagram. Okay, so as we said, the last stop of this oxygen-rich blood from the heart before it gets sent out to the body is going to be in the left ventricle. So what happens in that left ventricle before it enters into the aorta, it's not like this steady trickle of blood, right? So it's not like the veins where we kind of constantly have this blood supply traveling through it. It's either stop and go with the heart and with those proximal arteries. So the left ventricle, as it's, as that blood is, going through the lungs and kind of filtering through the heart in the previous steps, the left ventricle is kind of waiting. It's waiting to get all of that blood. It's waiting to get the blood from the right atrium to the right ventricle, to the lungs, back to the left atrium. Now it's saying, okay, all right, I'm getting this oxygen-rich blood. I'm the last stop. As that left ventricle is filling with that blood, pressure is going to be rapidly increasing, right? So the left ventricle is going to say, okay, great, I'm getting all this blood, ready to go. Okay, whoa, now I have too much. I got to shoot some of this out. I got to send some of this out to the rest of the body. So that's going to be the start of that cardiac contraction. So the pressure in the left ventricle is going to basically exceed the pressure outside of that left ventricle, and it's going to cause that aortic valve to open into that aortic arch. So when we're talking about pressure, you'll see as a theme throughout this PowerPoint, there is a comparison with pressure. So yes, we're kind of talking about standard pressure numbers. We'll kind of get to that a little bit, but we're talking about pressure in comparison from one location to another. That's going to be a big determining factor of how arterial blood moves, how this fluid is going to move. Pressure in one location is going to be different than pressure in another location, and that's how we get movement, not necessarily about the specific pressure number value itself. So pressure in the left ventricle is going to be higher than what it is in the aorta. So that valve, that aortic valve, is going to open, allowing all of that blood from the left ventricle to be ejected into that aorta to be sent out to the rest of the body. Now, the amount of blood that is ejected, like we said, typically going to be about 70 milliliters. That is also referenced as our stroke volume. So we'll kind of go back and forth between the pump, the 70 milliliters, but that's also in reference to stroke volume. Blood pressure throughout the entire body is going to rise every time we have a cardiac contraction. So every time we have blood ejected, every time we have a stroke volume in that aorta, our blood pressure is going to rise, right? Because now we have higher pressure in our arterial system from all of that blood that just got sent in from that left ventricle. So the increased blood volume is going to supply nutrients to our distal tissues, and that is going to be caused by an increased heart rate. So we need our blood pressure to rise. We need our heart rate to rise because we need to have high speed, basically. We need to have that stroke volume traveling at a high speed, at a high pressure, in order to get to all those distal sites of where it needs to go. So our heart rate is going to increase to help get that blood out to those tissues faster, right? So when we have a lower heart rate, maybe we're sitting, maybe we're sleeping, maybe we've been on the couch all day long, we're going to have less blood volume circulating through our body. But when we're up, we're walking around, we're talking, we're going through our daily activities, we're going to have a little bit of a higher heart rate because our distal tissues still need to get all of that arterial blood stroke volume from the heart. Now, when we're exercising, that increased heart rate is going to be beyond. We're going to have a really high stroke volume. We're going to have really high blood pressure to get all of that volume from that aorta, that aortic arch, down to those distal tissues. So the lower our heart rate is, the less blood volume we have. And the higher our heart rate is, the higher our pressure is, the higher our stroke volume is, or our blood volume is. So one thing really does affect multiple things, and it has a trickle-down effect. So pressure in and of itself, you should remember this from your physics course, it's going to be measured in millimeters of mercury, mmHg. The heart pump, like we said, that initial cardiac contraction is going to generate that potential energy or that pressure to move the blood throughout the body. So that initial amount of pressure, we are referencing that as potential energy because we're saying, okay, this ball of fluid, this little accumulation of fluid is going to have this much potential to get to where it needs to go. The stroke volume is going to generate a pressure wave. That's going to be our actual energy that travels throughout the whole system. That pressure wave propagation speed, so the speed at which that pressure wave is traveling throughout the system, the shape and the force of that wave is going to change as it travels. Now, of course, makes sense. The further away from our heart we're going, the slower everything is going to tend to travel. So our body needs to make up for that in reference to that loss of potential energy. We know that the further away from our heart we go, the smaller our arteries become, right? So we're losing more energy, but the arteries are becoming smaller. So in order to get into those smaller tissues, those more distal tissues, those smaller arteries, we need to be traveling at a higher velocity. So we need to see that pressure wave of that pump, that stroke volume. We need to see it almost kind of pick up speed the further away from the heart it goes. Now, we do have lower pressure in those more distal tissues or in those more distal arteries. And that's because they're smaller arteries, right? They don't need as much pressure. If we think about why proximal tissues, I keep saying tissues, if we think about why proximal arteries have higher pressure, it's because they're that much closer to the heart, right? So they have all of this pressure in that really proximal location close to the heart. As it gets further away, that pressure kind of relaxes a little bit in those vessels. So think about when you're in traffic. When you're in traffic, you're typically going to be in a city, right? Big highways, big roadways, a lot of cars, a lot of things going on, a lot of different pathways that all of these cars are going to take. There's a lot of pressure or congestion in big cities in terms of traffic. Now, as you kind of travel, maybe say you take 146 north and you're traveling and you're going through the Providence section, you're passing Branch Ave, and there's still a lot of traffic, but the highway kind of got a little smaller, right? Because instead of now 4 lanes of traffic, it's 2. So the pressure got a little bit less as you're passing Branch Ave, you're passing Mineral Spring, still kind of in like the outskirts of the city, right? So there's still a lot of cars, there's still a lot of people going every which direction, but pathways are a little bit smaller and you feel that pressure of that bumper to bumper traffic kind of lightening up, right? Everything's moving a little bit faster here. Now you're still traveling 146 north, you kind of get to Lincoln, you get up to North Smithfield, right? And then you get up into like the sticks of Massachusetts. And there are no cars on the highway. Everybody's traveling a lot faster than they were when they were stuck in that Providence traffic, right? Your vessels kind of got a little bit smaller, right? Because now you're kind of traveling through, the woodlands, I guess you could say, of Rhode Island and Massachusetts. So now you can travel faster. You can travel at a higher velocity to get to where you need to go as you travel further away from that Providence traffic. Hopefully that kind of helped make sense. So kind of keep that reference in mind. We're going to come back to that city traffic and that city congestion as we go through some of this fluid behavior. So pressure gradient. Our heart is pumping to maintain a high volume of blood in our arterial system. It has to kind of maintain that standard blood volume depending on what we're doing, right? So as we're more relaxed, our heart's not going to be pumping as much. As we're more active, our heart's going to be pumping more. So depending on what we're doing, depending on the need of volume of blood in our arterial system, that's going to indicate how much our heart is pumping. So when we have our heart pumping, it's going to cause a high pressure gradient between our arteries and our veins. The pressure gradient is a good thing. We need this to help us maintain normal standard flow. Pressure, as we know, is going to be greatest at the heart and it's going to decrease with distance. So again, think of that traffic. There's more pressure in Providence than there is when you're out in Barville, North Smithfield. Okay? So the further away we go, the less pressure there is and the more potential for you to travel faster further away with less pressure. So here is a pretty good diagram of what those pressure waves are going to look like depending on proximity to the heart. Our aorta, as we know, closest to the heart, a little bit further away, but still pretty close, brachial artery, and then radial artery a little bit further down our arm. Same thing with our leg, femoral artery. It's going to be a little bit closer to the heart than our dorsalis pedis artery is. Okay, so these are kind of similar in distance to each other. Upper extremities are going to be a little bit closer, of course, and these are going to be pretty similar in pressure wave. Now our aorta, if you look at that waveform, it's the lowest, right? If you're looking at that peak velocity, it's going to be much less than what it is at the DPA. So it's not really giving us a number here on our scale, but we can see with, just our eyes that that aorta is not traveling at a higher velocity than that DPA is. And that's because our aorta is under much more pressure. Providence traffic. You're not speeding in Providence traffic. You're going real slow, okay? Whereas, again, up in Barville, up in North Smithfield, you're probably pushing 80 on the highway. Don't want to hear that you're pushing 90 on the highway, right? Let's not be reckless here. But that's kind of the reference that is going to help you piece all of these behaviors together. Okay, so kind of continuing on our energy and continuing on our gradients here. Movement of any medium, especially fluids, is going to require two things. It needs a pathway, so we need to tell it which direction to go, and it needs a difference. It needs a gradient in energy levels. So if you have, hold on, before we get to our little explanation here, the amount of our fluid flow is going to depend on how severe that energy difference is. The greater the difference, so the greater the gradient, the more fluid is going to be able to travel, okay? It's also going to be affected by movement losses of the fluid. So as that fluid travels, we have friction that we have to account for. Any resistance in a pathway, we need to account for. So if a patient has plaque in their artery, that's going to be resistance to movement. That's something that we're going to have to consider when we're talking about energy levels and energy differences in terms of this fluid dynamic. So anything that can cause or really kind of oppose movement of fluid is going to be something that we have to account for when we're looking at the amount of flow getting from point A to point B. Like we said, the greater the energy difference, the greater the flow, and the greater the pathway resistance, the lower the flow. Okay, so we don't want resistance in a pathway, right? We don't want plaque in there. We don't want, any kind of stenosis or narrowing of a vessel in there, because that's all going to have an effect on the amount of flow that can travel through that section of the pathway and how that fluid behaves after it travels through that section of the pathway. So if we look at our example here, we said we want a greater energy difference and we don't want to have any resistance. So both of these vessels are not representing any type of resistance. We're not seeing any plaque, we're not seeing any thrombus, we're not seeing anything that's going to obstruct fluid in that vessel, in that tube. But what we do see is a greater energy difference with one of these vessels. So starting point, here's our starting point for each one. The starting point of example A, the energy difference there is 25 millimeters of mercury, right? So it's going from a location of 100 millimeters of mercury to 75. So there's an energy difference. We know we're going to get movement of flow. Our example B, we have an energy difference of 75 millimeters of mercury. So that's a greater energy difference. We're going to have a higher flow rate in vessel B because of that. Now, if we had pressure differences swapped, so say 75 millimeters of mercury was on this end of the tube and 100 millimeters of mercury was on this end of the tube, well, our fluid would no longer be traveling in this direction, right? It would be traveling in this direction. Fluid is going to travel from an area of high pressure always to an area of low pressure, path of least resistance, right? It's not going to travel upstream. It's not going to walk uphill to a higher place of pressure, right? That pressure is going to help it naturally move to an area of lower pressure. Okay, energy gradient, like we said, little recap here, it's necessary for blood to move from one location to another. Movement is only going to occur from a high pressure location moving to a low pressure location, like we just said. The greater the energy difference, so the greater the gradient, the more flow we're going to get. As blood moves outward to the distal tissues, towards the periphery of our body, it's going to lose energy just in the form of natural heat. Energy is continually going to be restored with each heart pump. So that nice give and take replenishment that we can always rely on our heart for. Potential energy, we mentioned this very briefly right at the beginning with that heart pump, also known as pressure. It's going to be the main form of energy in our flowing blood fluid. It is also going to be stored energy, and it's still going to be measured in millimeters of mercury. So again, just kind of piecing that together here. And then also kinetic energy. We're not necessarily talking too much about kinetic energy, but it's going to be the body's ability to create work as a result of velocity. So the energy of something in motion. We can kind of use kinetic energy to our benefit because once we have that moving heart pump, that moving stroke volume, it's not just going to completely stop, right? Unless there's an occlusion somewhere, unless there's a total blockage somewhere. And even then, it's not going to completely stop. That energy has to go somewhere. So the energy of something in motion is that broad term that we give to kinetic energy. We do measure it in terms of fluid density and velocity measurements. So if we have something kind of strange going on with our blood, maybe we have a coagulation disease, maybe we have really thin blood, that's all going to affect the amount of kinetic energy that our blood holds. And then gravitational energy. This is something that is very big for us, especially in the vascular world. This is also known as hydrostatic pressure, still going to be measured in millimeters of mercury. It's going to be equivalent to the weight of a column of blood extending from the heart to the level of where we are measuring that pressure. So that's just a fancy way to say that there is an inherent pressure on our vessels as we are standing due to gravity. And that's going to be kind of standard across the board. So we'll talk about this a little bit more. So let's say, for example, we have an average size patient who's laying flat on their back. We don't have the effect of gravity on any of our cardiovascular system because our entire cardiovascular system is at the same level of the heart. So we're going to have 0 millimeters of mercury in reference to our hydrostatic pressure against the vessels of our ankles. So typically when we're talking about hydrostatic pressure, we're talking about gravitational energy, we're really only talking about it in reference to our lower extremity arteries and veins. So when we're standing, we have negative gravitational energy or negative gravitational pressure on any vessel above the level of our heart. When we're standing, we have positive hydrostatic pressure on any vessel lower than the level of our heart. And if we kind of think about why that is, look at this diagram here. We'll go back to that slide in a second. Our patient is standing. Here's our heart. Our heart is our source. That's our origin of pressure. It's going to always be 0 millimeters of mercury in reference to only hydrostatic pressure. Okay, when we're talking about blood pressure, pulse, things of that nature, we have really high pressure at the heart. This is us talking about extrinsic pressure on our cardiovascular system due to gravity. Okay, so this is not talking about the amount of pressure that the heart is creating. It's talking about the amount of pressure that is on the heart from gravity. So this is going to be 0 at the level of our heart. We don't really take into effect any gravity at this level of the heart because that is right where our arterial system is starting, right where our cardiovascular system is starting. Now, as we're standing, we're talking about the weight of blood or the weight of fluid on our vessels as it kind of stacks down with gravity. So at our ankles, we're going to have about 100 extra millimeters of mercury in terms of hydrostatic pressure at our ankles because all of the fluid that is kind of sitting on these legs as we're standing, that's going to add pressure. That is the hydrostatic pressure. Now, all of the vessels above our heart are going to be negative Now this gets tricky because is this arm going to have the same amount of hydrostatic pressure on it as this arm? No, because this arm is below the level of the heart and this arm is above the level of the heart. So because it's above the level of the heart, it's actually going to use gravity to help pull down that weight from that fluid in those vessels. So it's going to have negative hydrostatic pressure working on those vessels located or positioned above the heart. This hand on the other side, it's hanging below the heart. So now it's going to have positive hydrostatic pressure on it. Do you ever feel like at the end of a long day, maybe you are a server and you've been on your feet all day, your ankles really hurt, but your wrists don't hurt, right? Because your wrists have been kind of above the level of your heart all day. You've probably been using your hands just as much as you've been walking around, but you haven't had that extra pressure on your hands as you have had on your feet throughout the day. And let's just make sure I covered all of this material on here. So like we said, we're going to have zero hydrostatic pressure on our heart at all times. So therefore, if our patient is supine, everything is at the same level as our heart, and there's going to be 0 millimeters of mercury on any of our vessels if the patient is supine. Now, when that patient is standing, our hydrostatic pressure is going to go into effect, and it's going to add about 100 millimeters of mercury against our ankle vessels. And then, everything will be slightly less pressure the higher up our legs we go. So again, if we look at this diagram here, our ankles, this diagram's using positive 105 millimeters of mercury. And at our wrist here that's hanging below the heart, that's probably like, 50 millimeters of mercury. Whereas the hand that's above the heart, negative 50 millimeters of mercury. Okay, so now we're going to talk about blood flowing through specific sections of a vessel. So we're going to talk about flow itself. Laminar flow is what we are referencing as our normal flow. This is stable flow. This is typical flow. It's going to consist of the fluid moving in layers, and the particles are kind of moving against each other, and they're all traveling the same direction with the same behavior. Now, that does not mean it's all traveling at the same speed or the same velocity. So this is going to be considered stable flow. It's going to travel in parallel layers, so that is referenced as plug flow. And parabolic flow is going to be when we have the middle section, right? So the fluid that's traveling through the most middle part of the lumen of the vessel is going to be traveling a little bit faster. We then have a stationary layer of flow or blood that kind of remains at the vessels of the wall. So think about when you're going ice skating, right? Everybody's skating in the same direction, or they should be. Sometimes you have those people who are not very nice. Everybody's skating in the same direction, right? So everybody's going, let's say clockwise. Everybody's going clockwise. Now you're still traveling in laminar flow. You're going the same direction. Now, there's typically going to be layers of ice skaters, right? So we're going to have plug flow. The slowest people, the people who are not that confident skating, where are they going to be? They're going to be hanging on to that wall for dear life, hoping that they don't fall and bust their butt. That's going to be our stationary layer, right? So they're kind of moving along, whatever, but they're going real slow and they're kind of just staying right along that wall. Then you have the people who are really good ice skaters, right? And they're zooming right past everybody. They're staying in their own lane, right? But they're kind of lapping the people who are staying along the wall. That's going to be the parabolic flow. That's going to be the fastest part of that fluid traveling in the middle. Those ice skaters are typically going to be in the middle of that ice rink. So factors that are going to affect how our flow behaves and if there's any potential resistance to that flow as it's traveling through our vessels. So our fluid movement, like we said, it's going to depend on the pathway that it's moving through and the fluid itself. So do we have a clotting disease? Do we have really thin blood? Are we on blood thinners? Does the patient have any plaque in their vessels? Do they have any kind of vascular anomaly? Do they have a duplicate system? All of these things are going to affect how fluid moves through our system and the flow of the flow of that fluid itself, how it behaves. So viscosity of the fluid and vessel length of the pathway are going to influence resistance. Now, the bigger change in resistance is going to come more from vessel diameter. So vessel length, viscosity, yeah, they're going to influence the resistance a little bit, because obviously if you have like a super thick blood traveling through a blood vessel, it's going to have more resistance, right? There's going to be more resistance from getting that fluid from point A to point B. Vessel length, of course, the longer our vessel is, the more resistance there's going to be, because it has to travel a further distance. When we have a change in diameter, we're now saying, okay, you had all of this space, you had all of this lumen space to travel through, but now you don't. So now we're going to say, whoa, that's a lot of resistance in that area, because now I have to travel through this very, very small pathway. So there's a lot of resistance when we have a change in vessel diameter, because there's just not as much room as there was for that fluid beforehand. So that vessel is saying, yep, I got smaller and I'm going to be more selective. It's kind of like when you're waiting out, like when you're waiting to like get into a club, right? And everyone's kind of like waiting in line. That pathway is really small, and they're going to kind of say, nope, you're not on the list, right? So not everybody gets in, even though they're waiting to get through that pathway, through that bouncer into the club. You guys, I'm really showing my age here, okay? Don't make fun of me. Now, friction is also going to have a big influence on resistance to flow as well. So there's going to be friction anywhere, regardless. It's just a natural part of our cardiovascular system. Energy loss happens, and that's why we have this constant replacement of blood supply from our heart pump to account for all of that energy loss, right? So we need to make sure that our tissues are getting as much of that oxygen-rich blood as possible, and we have to take into account losing some of that energy to get that fluid from point A to point B is going to come from friction and energy loss. So we're going to have internal friction within a fluid. We're going to really kind of determine how much friction will occur based on its viscosity. So the more viscous a fluid is, the thicker a fluid is, the more friction we're going to have. We're going to lose that energy in the form of heat, because the red blood cells are going to be rubbing up against each other, and that inherently is going to make them tired. So we're going to lose that energy from just blood being blood in the form of heat. We are going to see increased viscosity with patients who have elevated hematocrit. So anybody who has more red blood cells in their body than normal is going to have more viscous blood, therefore more energy loss due to friction. Small vessel size, like we said, so a decrease in vessel diameter is going to result in an increase in friction losses, again, kind of leading to that increase in resistance. So energy losses, like we said, viscous energy losses are going to be caused by that friction within the fluid itself. There is a natural friction loss of a normal healthy person, but of course the more viscous our blood becomes, the more friction we have and the more energy loss we have due to that. We also do have just inertial energy losses. So this is going to be caused by deviations from laminar flow. So anytime there's something going on in a vessel that's going to change that blood flow's direction or velocity, or velocity, that is when we're going to have kind of bigger chunks of energy loss. So anytime we have that parabolic profile flattened, meaning we no longer have that fastest velocity traveling right through the middle, anytime we have that flow traveling in a disorganized pattern, so they're not traveling in nice parallel layers, and we're typically going to see this in areas of stenosis. So when we have that abnormal narrowing of a vessel, this is not talking about the normal decrease in diameter of an artery getting smaller the further away from the heart it gets. This is talking about the abnormal narrowing of a vessel that shouldn't be narrow in that area. So a stenosis, abnormal narrowing of the lumen of a vessel. A stenosis is going to have a drastic effect on blood flow, on fluid flow, and on how that fluid behaves. So typically, when we have a stenosis, we're losing that laminar flow. The blood is going to say, whoa, I was not expecting to run into this roadblock here. So now I don't know what to do. It gets all confused. It kind of scatters. And because it's scattering, we're going to have a lot of energy losses from that. We'll talk about stenosis a little bit more. I don't want to get too into that at this very moment. We will come back to stenosis quite a bit. Anytime I do an equation on slides, as you guys know, with Collaborate, it doesn't come over nice and pretty. So just reference the slide back to the PowerPoint that's posted. Puicel's equation is something that I am not going to torture you with. I'm not going to ask you a math question regarding Puicel's equation, but I will ask you theory questions on this. So anytime I know we see equations, we kind of freak out a little bit. You guys just took your SPI, so you're like, oh God, no, not more equations. You need to know what this equation stands for, what it helps determine, and how these factors behave. So you have to answer theory questions on this, but I will not be asking you to actually calculate these equations for my class. The registry, the RVT exam, different beast. They may ask you calculation questions based on this. So Puicel's equation, what it is it's going to help us to determine the relationship between pressure, volume flow or flow volume, and resistance. So these three big topics that we've been talking about. It's going to answer the question of how much fluid is moving through the vessel at a particular area. So we're using vessel radius. Like we said, vessel diameter is going to be most sensitive to producing the amount of resistance. A decrease in that radius is going to have a very severe increase in resistance. And when we have a higher increase in resistance, our volume is going to decrease. So because of that, we have to have our velocity increase. Okay, so we're talking about a normal healthy patient here. As our arteries get smaller, further away from the heart, we have a drastic increase in resistance. Those vessels say, whoa, 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 I'm too small. I can't have all of this blood flow coming in. So I got to be selective on who I let in. But the blood volume has to get to those tissues, right? The blood volume itself, that's the fluid. It's saying, okay, well, I don't care like how small you are, but like we got to figure out a way because I got to go supply those tissues. You're like gatekeeping here. So the velocity in response to that says, okay, this says to the volume, okay, we got to travel faster to kind of blow right past that resistance, right? Or to try to kind of get through that resistance a little bit easier. So we're going to behave in a nice organized fashion. We're going to go 2 by 2 like Matilda, again, aging myself here. And we are going to get through those smaller vessels to get to where we need to go. But in order to get past them, we got to go fast. So think about track, right? Any of you guys ran track? Any of you guys ran hurdles? Or if you've ever even watched the Olympics, people running hurdles, do you ever see people jumping the hurdle while they're jogging? No, they're sprinting to get over those hurdles, right? So they're saying, okay, there's literally an obstacle in this pathway, right? The vessel's smaller. The smaller the vessel is going to be our hurdle here. In order for that person's body to get over the hurdle, to keep going, they have to sprint. They have to be going very fast. So their velocity has to increase in order to get over that hurdle to continue going to where they need to go to get to that finish line. I really hope all of my analogies work, guys. If they don't, please just tell me. Okay, so pressure and velocity relationships. Now we have Bernoulli's principle. Again, I'm not going to torture you guys with calculating specific scenarios. I'm not going to give you a kinetic energy number and you have to add it with the gravitational energy number. I'm not going to do that to you guys, but you have to understand what these concepts are, what these principles are, and the relationships between them all. So Bernoulli's principle is going to be the total energy of fluid is the sum of all energies. So the energy of our fluid is going to take into account all three types of energy that we've talked about. So potential, that's kind of our general blood pulse that we've been talking about as it travels through vessels. Kinetic, the ability of that to to perform work, much smaller number than our potential energy is. And then gravitational pressure, we have to account for that, especially when our patient is standing, going through normal day-to-day tasks. If one of these energies increases, the other must decrease in order for our total fluid energy to stay the same. We want that total fluid energy to stay the same. So usually it's going to be the kinetic energy that kind of takes the back seat, right? So say we have a increase in potential pressure and gravitational pressure. Maybe our patient's going for a run, right? So they have an increase in that potential pressure because there's more stroke volume coming out of that heart, and they also have gravitational pressure on their legs because, well, they're up and running, right? Kinetic energy, that's the ability to perform work. Okay, well, it's like the ability to perform work. We don't have to rely on kinetic energy to perform those tasks because we have the potential pressure and the gravitational pressure already having increased to account for those tasks. So now our kinetic energy can kind of take a back seat in that scenario. Our velocity and pressure are going to be inversely related, like we said. So when we have an increase in pressure, our vessels are going to be traveling at a slower velocity. And when we have a decrease in pressure, our vessels are going to be traveling at an increased velocity. Same thing kind of goes with resistance, right? So we'll get there in 1 second. I do want to kind of just briefly put together the flow as well. Sorry, 1 second, guys. Little coffee sip break. Okay, thank you. So when we have our flow, we have steady flow, like we talked about, kind of, and then we have pulsatile flow. When we're talking about the arterial system, we are talking about pulsatile flow. We're not really talking about steady flow. And you're probably like, okay, well, what did you just say on slide number, where did it go? 14, right? We just kind of talked about laminar flow. And that's still true. Laminar flow is still true for pulsatile flow. But steady flow, the term steady flow, is going to really be something that is not in the human body. So this is going to say that it is originating from a steady driving force. This is a very predictable behavior. So in a normal rigid tube, energy losses are going to be mainly viscous. And you're like, okay, well, what is steady flow if we don't have any of that in our body? Steady flow is going to be like a garden hose, right? So you turn the water on and it's steady until you turn it off. Predictable behavior, right? Travels in a normal rigid tube. Of course, the longer that hose is, the further down that hose it gets, we're going to have energy losses that are different than where it is proximal in the hose. Okay, we don't have any vessels in our body that behave like that. Pulsatile flow, we're having changes in our pressure, and our system is going to respond to that pressure. That's going to be our arterial flow. You're probably thinking, well, why isn't venous flow steady? Well, because it responds to our system, right? Our system responds to venous flow. When we take a big breath in, when we blow that breath out, when we're sitting, when we're laying down, all of that has an effect on our venous flow. So we don't have vessels in our body that are traveling at the same velocity from the same steady driving force forever. We just don't. So we're going to be talking about pulsatile flow. Pulsatile flow is going to only be for the arterial system. Okay. We also have phasic flow, which we'll talk about in a second, and that can reference arterial or venous. So pulsatile, we don't have any steady in our body. Pulsatile is our arterial system. Phasic can be either. So pulsatile, changes in our driving pressure conditions in our body is going to respond to those pressure changes. We see this in reference to systole and diastole. So the start of that cardiac contraction and then the waiting period at the end of that cardiac contraction. Systole is going to represent forward flow, and then diastole on our waveform is going to be this little area, this temporary area where we see a little bit of flow reversal due to negative pressure in our ventricles and an increase in peripheral resistance. So kind of just take that for what it is. Diastole is when we're waiting for that next cardiac contraction. So we get a little bit of negative pressure in that left ventricle before we're waiting for it to fill. Once that left ventricle fills, we shoot that blood out into the aorta. That's going to be systole, right? So systole right at the start of that cardiac contraction, left ventricle's opening into the aorta. Once it shoots that out, it then enters a state of diastole where it gets this little kind of negative pressure because it just had such a high pressure before with systole. With pulsatile flow, we're also going to see changes in acceleration. We could see deceleration, and we could see changes with resting. Of course, pretty straightforward there. Now, peripheral resistance, like we said, we have some vessels that are going to be typically low resistance, some vessels that are going to be typically high resistance. So low resistance vessels, these are going to be continuous, steady nature feeding of a vascular bed. This does not mean they are steady flow. These are still going to be some sort of either pulsatile or phasic, okay? So it's coming from a steady nature, right? So meaning it's typically not gonna be like this very aggressive arterial pulse. These are gonna be a little bit slower, a little bit, I don't know what I'm trying to say with that. I don't know what these are trying to be. They're not trying to be anything. So our low resistance vessels, they're feeding a vascular bed. They're going to have a continuous flow, right? All of our arteries, all of our veins have a continuous flow. But high resistance vessels, these are going to be very, very pulsatile. Like we said, high resistance, the fluid needs to travel faster, needs to have a higher velocity to get through that high resistance vessel. When you have a vessel that's lower resistance, it can kind of travel a little bit slower, right? There's not as much obstructing it or blocking it from getting to where it needs to go. So it doesn't have to travel as fast. So some of our lower resistance vessels are going to be our ICA up in our carotids where we have our carotid split. Our ICA is responsible for feeding our brain. So we don't really want a very high velocity vessel to be entering into our brain, right? We kind of want to have something a little bit slower entering into that brain, right? So our ICA feeding our brain, it's a low resistance vessel, so it's not requiring the fluid to travel at a very high velocity. Same thing, our vertebral, that's also going to be part of our circle of Willis up in our head. We will learn about that. Our renal arteries, our celiac axis, our splenic artery, and our hepatic artery. These are all going to supply important structures, right? Important organs. These are like direct arteries to these tissues. So we don't want them traveling at a very high velocity. So we're going to make sure that these vessels are low resistance. These vessels are saying, okay, we're low resistance. Come on in. Everybody can come on in. We want to get as much blood supply as possible, right? Take your time. It's fine. Relax. Stay a while, right? Whereas when you have the high resistance vessel, these are saying, okay, we got to get to where we're going. We got to get there fast. So we have our ECA, we have our subclavian artery, our aorta, right? High resistance vessel, a lot of pressure. And then we have our iliac, our extremity arteries, and our fasting SMA. We'll talk about that fasting SMA in a few weeks when we get into more of our in-depth arterial evaluation exams. These are typically going to display diastolic flow reversal when we're looking at them in terms of the waveform. So low resistance vessels, we need to have a slower velocity entering into these tissues. So these vessels are going to be lower resistance. Remember when I said I wasn't going to cough during this PowerPoint? Lied. High resistance vessels, these are saying, okay, these vessels are typically small or they're under a lot of pressure. So these are usually going to have a higher velocity in reference to that. The exception to these high resistance vessels are going to be the aorta. So the aorta, even the subclavian, they're under a lot of pressure. So they're high resistance and also high pressure. So they're not really going to be traveling as fast as, say, the ECA is up in the face, where the extremity arteries are further away from the body. So there are some exceptions to these behaviors. Our arterial waveform, we talked about systole, we talked about diastole. So systole, the contraction of that left ventricle entering right into the aorta. Diastole is that period of time when the heart is refilling after systole. Diastole is also where we see a little bit of that negative pressure shift in that left ventricle. So we see sometimes a little downstroke in our waveform. We have peak systole, so that's our peak systolic velocity. We've talked about this throughout the program, PSV, when we're measuring an artery waveform. It's the point of the peak velocity within the cardiac cycle itself. And diastole is the point of where that diastolic velocity ends, just prior to the next systolic waveform. We also have a dicrotic notch that we can see in some waveforms, and these are going to be a small downward deflection in the arterial pulse, marking the end of systole. This is not representing diastolic flow reversal. So we'll see what these kind of look like. Dicrotic notches are still going to be in that forward moving flow. So here is our baseline. Right, here is our normal waveform. So this is systole. Pressure is really, really high because we just had that contraction in the left ventricle. And then as that fluid travels further away from the body, we're seeing that pressure decreasing in the left ventricle here. Our dicrotic notch, kind of like a little area of plateau. And then diastole, pressure is really dropping as it's waiting for the next one to come. And all of this is still forward moving flow. We'll talk a little bit about flow reversal on our next slide here, or I think it's in 2 slides. So have a little example here to kind of piece systole, diastole, resistance, all of this together. If you drop a golf ball and there's no floor, so there's no resistance, there's no blockage of the pathway, it keeps moving downward, just as blood is going to do during systole, right? So systole, shooting that blood out. If there's nothing to stop it, it's going to keep going. If you drop the golf ball onto the floor, okay, well now we have a blockage in that pathway. It's going to change its direction, right? The golf ball is going to bounce off that floor and go back to you. That's going to be early diastole. So early diastole, like we said, that pressure is changing because it was just under all of this super, super, super high pressure in that left ventricle. Then it shot all of the blood out, and now it's like, whoa, now I have no pressure in my left ventricle. So it's changing its direction. Now, if you put your hand out, so you drop your golf ball, it hits the floor, bounces back. If you put your hand out as the golf ball is traveling back to you, it's going to hit your hand, so resistance again, and then it's going to travel back down towards the floor. So another change in direction. That's going to represent our late diastole. This is where we're going to start to see flow reversal on our waveform. So this is not occurring in every waveform that we're looking at. This is not occurring in every artery in every part of the body. This is in specific locations. So this is sometimes, depending on where we see it, can be considered normal. Other times, depending on where we see it, might not be normal for that section or for that artery in that area. So we have 3 types of phasicity that we can look at arterial waveforms in. Depending on, again, where that artery is, what artery we're looking at, they each are going to have a different variation of normal for phasicity. Like we said before, sometimes it's normal to see reverse diastolic flow. Sometimes it's not, depending on where we are. So triphasic. This is going to be where we see 3 clear-cut phases in a waveform. This is also known as multiphasic, but no one really says that. It's triphasic. We typically see this in distal peripheral vessels. With a triphasic waveform, we're going to see a very rapid upstroke to a pretty high velocity. We're going to see a rapid downstroke, and then we're going to see possibly a dicrotic notch, but we're usually going to see a short period of diastolic flow reversal, and then an upstroke to that late end diastolic forward flow. So like we said, rapid upstroke to a pretty high peak velocity, rapid downstroke to even flow reversal during that early diastole, and then it's going to come back up to forward flow for late diastole before the pressure increases in our left ventricle to have our next waveform. So with this, we don't want to see spectral broadening, right? So let's remember from physics, spectral broadening is going to be all of this area in the waveform, right? We don't want to see that filled in. We want to see just nice, clear lines. Now we're going to have an initially high velocity with our forward flow. That's going to be our systole. We're going to have that brief phase of flow reversal, early diastole, and then we're going to have a lower velocity forward flow for our late diastole. So that's the standard appearance of a triphasic waveform. Now, sometimes you can still have a triphasic waveform without flow reversal. So what would that look like? Let me just erase here because I don't have too much space on here. So here's our, here is our baseline. Now, sometimes you can have a waveform that looks like that. And that can still technically be considered a triphasic waveform. We have systole, dicrotic notch, and diastole. And that dicrotic notch would represent early diastole and then late diastole after. So you can still have three phases of this waveform, of this cardiac contraction, without that middle phase or that early diastolic phase being flow reversed. And that all has to do with the amount of pressure in that ventricle at that time. So flow reversal is going to occur in high resistance vessels and undergoing periods of vasoconstriction. And then also we are going to see some flow reversal decrease with vasodilation. So anytime our body is heating, whether we be exercising, whether we are exercising, or if there's a stenosis in a particular area, that's all going to account for body heating, and that's going to result in vasodilation, where those vessels dilate wider than they typically are, and we'll see decreases in that flow reversal. So we're less likely to see that diastolic flow reversal in a patient who is exercising, or in a patient who's exercising. I want to clarify on here. So vasoconstriction is sort of like a stenosis-like concept, right? So our vessels are constricting. Now, you're probably thinking, okay, that's like the same as a stenosis, right? The stenosis is the narrowing of a lumen. But the difference with the stenosis is that that is abnormal. That should not be in any section of an artery or a vessel. And because of that, remember with that laminar flow, where we get that when we have any kind of variation of that laminar flow, anytime that flow is traveling in a disorganized pattern, we're going to have drastic heat and energy losses. So the stenosis itself, yeah, it's technically considered constricting the vessel, but what it's doing is it's heating up. It's having more energy loss because the red blood cells are rubbing together, creating heat in that area. That's going to result in vasodilation in response to that increased heat in that area from the stenosis. Vasoconstriction, in its own sense, is more of a natural process. So our body is used to scenarios where our vessels are going to vasoconstrict, whether we're cold, right? Certain things are going to result in vasoconstriction that our body is normally accustomed to. So stenosis with this, yes, it's the narrowing of the vessel, but the main issue with stenosis is energy loss in the form of increased heating. And that heat is going to create the vasodilation, meaning that flow reversal will decrease in that abnormal scenario. Okay. There's a lot of like multi-step thinking through a lot of these concepts. So if you have questions about this stuff, guys, you have to ask me. Okay, so moving on, we just talked about triphasic, now we have biphasic. So 2 phases, we're gonna have a less rapid of an upstroke, so typically not as high of a peak systolic velocity as we do with a triphasic waveform. We're usually not gonna see a dicrotic notch in these waveforms. We're gonna have a period of early end diastole. We could potentially see flow reversal, but we're usually not gonna see it below that baseline. So kind of, give or take a little bit close to that baseline, but not necessarily completely below it, and then we'll see it followed by forward flow. So end diastolic flow may be non-existent or could be flattened but continue to move forward. We could potentially see no flow reversal but continued forward flow, and we could see a varying degree of spectral broadening. Now, again, remember, depending on where we are evaluating, biphasic flow could be abnormal, right? So if we're looking at a vessel that should have triphasic flow and we're seeing biphasic flow with spectral broadening, that needs to trigger to us to say something abnormal is going on in this vessel. Now, if we're looking at a vessel that just typically has biphasic flow, then we aren't concerned about it. And as we go through learning about specific exams and specific vessels, we'll learn about what those vessels should look like in those areas. So the meat and potatoes of arterial waveforms should be triphasic. Biphasic is kind of this gray area where it could be normal, could be abnormal, depending on where we are. Here's that biphasic waveform. So we still have that kind of semi-rapid, we have that, upstroke here, and then we don't really have like too much going on in this general area, right? So it's kind of just like, all right, we have our systole here, and then we have our diastole here. Not really like much detail going on about those phases. And then lastly, we have monophasic. So this is where, our peak systolic flow is going to be much lower. We don't really have a rapid upstroke or a rapid downstroke. We don't really have flow reversal or really an indicative part of early versus end diastolic flow. It's kind of just like one little hump. We don't want to see monophasic flow anywhere. So monophasic flow is not going to be considered normal anywhere where we're looking. So we need to further evaluate that. We typically see spectral broadening with monophasic flow as well. So you can see that in this waveform here, that all of that spectral window is filled in, and we don't want it to be. If we go back to our biphasic flow, we could probably put our gain down a little bit on this waveform, but we'd probably still be getting some echoes in that spectral window for this one. So monophasic, not normal at all. Here we kind of piece them together. So we have triphasic, biphasic, and mono. We'll kind of come back to, you'll definitely see more of this sort of image as we get into our vascular technology exams at the end of the semester. We're going to be learning about ABIs, we're going to be learning about segmental pressures, and a lot of those exams are non-imaging. So we use blood pressure cuffs and a Doppler transducer to evaluate how different segments of our arteries behave to different levels of pressure. And this is typically how those machines read it. So this is really all we're going off of on those exams. So we'll definitely come back and we'll see a lot more triphasic versus biphasic versus monophasic on these little chart graphs as we move through the rest of the semester. So please, 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 guys, make sure you have a solid understanding of this. This is a really big part of your registry. Arterial behavior is a big part of this course. So if you don't understand a topic or you don't understand how one topic relates to another topic, please come to me and I will try to kind of give you another analogy to use to kind of help get that to stick in your mind. So use the reference of traffic, use the reference of, running in a race. All of those things should help you piece these concepts together and be a tool to help you remember those baseline formalities of these themes and of these topics. So I only made it through with coughing twice. Love that for me.